I'm Dr. Stephen Roman. This talk is on regenerative medicine for peripheral neuropathy, a review of the clinical literature. We'll be reviewing human clinical studies using preparations from patients' own blood, namely platelet-rich plasma, or PRP. Topics I will cover in this review include diabetic neuropathy, Hansen's disease or leprosy, carpal tunnel syndrome, nerve injury, neuropathic pain, and regenerative adjuncts to nerve surgery. To start out, how does platelet-rich plasma work in neuropathy? Platelet-rich plasma, or PRP, induces the release of cell signaling molecules such as nerve growth factor, vascular endothelial growth factor, and fibronectin. These are involved in reduction of inflammation and the formation of new nerves and blood vessels. They also activate Schwann cells, which are the cells that cover nerves and help keep them healthy. Plasma-rich growth factors, or PRGF, is a type of PRP which can be used as an injectable scaffold to assist in nerve repair. PRGF consists of a pool of growth factors, microparticles, and other bioactive mediators, many of them trapped through fibrin heparin sulfate binding domains in a three-dimensional transient fibrin matrix. Once PRGF is injected inside a nerve or intraneurally as a liquid-to-gel injectable scaffold, or perineurally or around the nerve, the fibrin breaks down, releasing cell signaling molecules such as neurotrophic nerve growth factor, brain-derived neurotrophic factor, insulin-like growth factor 1, platelet-derived growth factor, vascular endothelial growth factor, hepatocyte growth factor, and neurotrophic factors such as fibrin, fibronectin, and vitronectin. How does PRP affect nerve regeneration? Evidence suggests that the therapeutic effects of PRP on nerve regeneration are due to neuroprotection and prevention of programmed cell death, stimulation of new blood vessels, enhancing axonal outgrowth capacity, overcoming the inflammatory microenvironment, and decreasing denervated target muscle atrophy. The first publication we will review is a study on diabetic neuropathy. Hassanian and others published a randomized controlled trial in 2020. The first group of patients underwent medical treatment plus perineural PRP injection around the following nerves: median, ulnar, tibial, superficial peroneal, deep peroneal, and sural nerves. The second group had medical treatment only. Pain scores and the modified Toronto clinical neuropathy score were measured at 1, 3, and 6 months. The patients in the PRP group had significantly better scores at all time periods tested. Pain improved in the PRP group from 7 out of 10 at baseline to 1 out of 10 at 6 months. Pain worsened in the control group from 6 out of 10 at baseline to 7 out of 10 at 6 months. Nerve conduction studies demonstrated significant improvement in the PRP treatment group as compared to the control group. Next, Hansen's disease or leprosy, which causes peripheral neuropathy. Angiani and others performed a randomized controlled trial on 60 patients with leprosy peripheral neuropathy. Treatment consisted of PRP injected perineurally about the ulnar and tibial nerves. The control group was injected in the same sites with platelet-poor plasma. Pain scores and 2-point discrimination testing were measured at 2 weeks. There was significant improvement in pain and 2-point discrimination testing in the PRP group, with no change noted in the control group. There are 4 studies looking at PRP injection for carpal tunnel syndrome. Uzan and others in 2016 compared PRP to steroid injection for carpal tunnel syndrome. 20 patients were injected with PRP and 20 patients were injected with steroids. They compared nerve conduction studies as well as the Boston Carpal Tunnel Questionnaire at 1, 3, and 6 months. The results showed that nerve conduction studies did not differ between the groups. The Boston Carpal Tunnel Questionnaire categories of symptom severity and function were superior in the PRP group at 3 months, but there was no difference at 6 months. Another carpal tunnel study performed by Wu and others was a randomized controlled trial on 60 patients comparing PRP injection to nighttime wrist splinting. The primary outcome measure was pain. Secondary outcomes were the Boston Carpal Tunnel Questionnaire, cross-sectional area of the median nerve, nerve conduction of the median nerve, and finger pinch strength. At 6 months, the PRP group had significant improvement compared to the control group in pain, Boston Carpal Tunnel Questionnaire score, and cross-sectional area of the nerve. Nerve conduction and finger pinch differences were not significant. Another randomized controlled trial by Regenerative and others on 41 subjects compared splinting alone to splinting plus PRP injection. After 10 weeks of follow-up, pain, Boston carpal tunnel questionnaire, and nerve conduction findings improved in both groups with no significant difference between the groups. It is of note that the injections in this study were performed without ultrasound guidance. The fourth study by Atwa and others looked at 36 patients with mild to moderate carpal tunnel syndrome, comparing injection of PRP to a steroid injection with 3 months follow-up. Nerve conduction studies improved similarly in both groups. At 1 month and 3 months, pain levels, functional status, and symptom severity improved in both groups, but significantly more so in the PRP-treated group. Average pain score in the steroid group was 7.2 at baseline and 5.2 at 3 months. Average pain score in the PRP group was 7.1 at baseline and 3.4 at 3 months. We have 2 reports on nerve injuries treated with PRP. Sanchez and others reported on a case of a 28-year-old man who suffered a soccer injury to the knee with anterior cruciate and lateral collateral ligament tears. The ligaments were surgically repaired. 9 months after trauma, he had a foot drop with very little activity on electrophysiologic studies, and he was considering tendon transposition surgery. With serial injections of plasma-rich and growth factors, he was able to run at 5 months. At 23 months, strength improvement from baseline in the tibialis anterior was from 0 out of 5 to 3 out of 5, in the peroneus longus from 1 out of 5 to 5 out of 5, and in the extensor hallucis longus from 1.5 to 3 out of 5, and sensation returned to almost normal. The second case report on nerve injury was by Garcia de Cortazar and others, who reported a case of transection of the radial nerve, which showed no signs of clinical or electrophysiologic recovery at 3 months postoperatively. At month 4, serial intraneural injections of plasma-rich and growth factors were begun, the first 3 at 2-week intervals, followed by several more serial injections at varied intervals. At 11 months of treatment, functional recovery was achieved, with EMG demonstrating complete reinnervation of the radial supplied musculature. We have 1 study on neuropathic pain. Lopez and others reported on 45 patients with various neuropathic pain syndromes lasting greater than 3 months. Patients were treated with ultrasound-guided perineural infiltration of PRP. At 3 months, there was a 70% decrease in average pain scores, from baseline of 9 over 10 to 2 out of 10. 50% of patients reported complete resolution. The average McGill pain questionnaire score improved from 6.5 out of 10 at baseline to 1.9 out of 10 at 3 months. Finally, there are several publications using PRP as a regenerative adjunct to nerve surgery. Kuffler and others reported on a case of a 48-year-old man who suffered a severe and extensive ulnar nerve trauma with excruciating neuropathic pain. 3 years after the trauma, a collagen tube filled with autologous platelet-rich fibrin was implanted. This allowed limited motor and sensory function across a 12-centimeter nerve gap, while decreasing the pain level to tolerable at 3 years follow-up. Hibner and others reported on 10 patients who underwent repeat operation for persistent pudendal neuralgia after failing to improve after initial surgical decompression. A transgluteal decompression was performed in the 10 patients, and after adhesiolysis, the nerve was coated with PRP. 1 patient was lost to follow-up. 8 of 9 improved, and 1 reported no change. The average pain scores decreased from a baseline of 7.2 to 4, with a follow-up of 23 months. Scala and others in 2014 performed a randomized controlled trial on 20 patients undergoing parotidectomy. The treatment group had PRP applied to the surgical site, while the control group did not. Although this was a small number of patients, there appeared to be a protective effect of PRP in regard to neurologic deficits. Mazzafarian and others performed a small randomized controlled trial on 10 patients with acute median nerve injuries undergoing surgical nerve repair. At the time of surgery, 5 patients received PRP, both intraneurally and at the repair site, and the 5 controls did not. Outcomes were the same at 1 year. Tabrizi and others performed a randomized controlled trial on 21 patients undergoing a sagittal split osteotomy of the mandible. Neurosensory disturbance is common after this procedure. Each patient had platelet-rich fibrin applied to the surgical site on one side intraoperatively, and the other side served as the control. The platelet-rich fibrin side demonstrated significantly better sensation and less paresthesias at 6 months. Finally, Troll, Awir, and others evaluated PRP as an adjuvant to carpal tunnel release in a randomized controlled trial. After surgical release, 25 patients had their carpal tunnels irrigated with platelet-rich plasma, and the control group of 25 patients had theirs irrigated with platelet-poor plasma. The primary endpoint was hand grip, which was superior in the PRP treatment group at 6 weeks. In conclusion, no serious side effects were reported in any of the studies in this review. PRP is a promising therapeutic tool in the conservative treatment of peripheral nerve pathology and as an adjuvant in nerve surgery. Further studies are needed in the search for more effective approaches to this difficult-to-treat condition. Thank you.